Okay, it looks like it's about 12:02. Maybe we'll have a few additional people joining us as we get moving. Thanks for logging on to this webinar today. This AUA webinar sponsored by Ferring Pharmaceuticals. My name is Aditya Bagrodia. I'm a urologic oncologist at UC San Diego. It's a pleasure to be here. Would love to keep this interactive. Feel free to put any questions in the chat, and we can certainly address those towards the end of the talk. So today we'll be talking about Adstiladrin. The generic name for it is nadofaragene faradonovec, and it is the first and only FDA-approved intravesical non-replicating gene therapy for patients with high-risk non-muscle invasive bladder cancer. And again, my name is Aditya Bagrodia. Today's webinar is sponsored by Ferring Pharmaceuticals, and I am presenting on behalf of Ferring and receiving compensation for this presentation. So this first slide has some critical safety information, and I'm going to read it as written just so we're all crystal clear on it. So there are a few contraindications that are worth mentioning. Adstiladrin is contraindicated in patients with a prior hypersensitivity reaction to interferon alpha or to any component of the product. There is a risk with delayed cystectomy, and specifically delaying cystectomy in patients with BCG-unresponsive carcinoma in situ could lead to the development of muscle invasive or metastatic bladder cancer, which can be lethal. If patients with carcinoma in situ do not have a complete response to treatment after 3 months, or if carcinoma in situ recurs, consider cystectomy. And I think this particular warning and precaution cannot be overemphasized. It's amazing that we have new tools in the toolkit and continuing developing tools. But when you look in a patient's bladder after they received BCG, recurrences can take a lot of different shapes, sizes, and clinical manifestations. If you see multifocal, high-grade, nodular, sessile tumors occupying majority of the bladder with carcinoma in situ, that may be a patient where cystectomy may be the appropriate next step. And I think that this is where experience managing patients with bladder cancer, performing cystoscopies, getting transurethral sections prior to engaging on bladder-sparing strategies is absolutely critical. So I think this is a real part of the conversation that needs to transpire with the patient. Really, honestly, for the patients that have high risk non-muscle invasive bladder cancer and are starting down their journey. The second risk comes along with disseminated adenovirus infections. And people that are immunocompromised or immunodeficient may be at risk for disseminated infection from Adstiladrin due to low levels of replication-competent adenovirus. And ideally, you could avoid Adstiladrin exposure to immunocompromised or immunodeficient individuals. If you look at the literature regarding immunocompromised people, and we'll take perhaps people with HIV and people that are receiving immunosuppressants after transplants, extrapolating from the BCG literature, it's generally reasonably safe. The efficacy may be present, but at slightly lower rates. And I, until the data matures, kind of use those general guidelines in my practice as well. In terms of dosage of administration, it's intravesical instillation only. This is not IV or IM or any other route. It's to be instilled within the bladder. And there's no indication for a topical or oral route of administration as well. A couple of unique considerations. Females of reproductive potential should use effective contraception during Adstiladrin treatment and for 6 months after the last dose. And a male patient should be advised with partners of reproductive potential to use effective contraception during Adstiladrin for 3 months after the last dose. And then finally, adverse reactions. And of course, we'll talk about this at some length when we run through the data. The most common adverse reactions include lab abnormalities, such as glucose increases, instillation site discharge, triglyceride increases, fatigue, bladder spasms and micturition, urinary frequency and urgency. These are kind of things we expect. Transient increases in creatinine, some hematuria, decreases in phosphate, chills, fevers, and dysuria. And any negative side effects should be reported to the FDA. And here's the contact information both on the internet as well as phone, along with Ferring's contact information as well. So once spend just a moment talking about the company. So Ferring is a research-driven specialty biopharmaceutical company committed to helping people build healthy families and live better lives. Um, some of these drugs may appear familiar to you. For instance, Firmagon is a medication used for patients with advanced prostate cancer for those receiving radiation therapy. And then there's a host of drugs in the reproductive and maternal health space, endocrinology, ortho, and GI as well. And here you can just see a summary of their current U.S. portfolio. Okay, so now let's kind of jump on into it and discuss bladder cancer and challenges in non-muscle invasive bladder cancer. Something that I think is often overlooked. Bladder cancer is the sixth most common cancer in the United States. It's the fourth most common cancer in men. And about 75% of new cases in 2024 did occur in men. Overall, we see just over 80,000 cases in the United States annually. The incidence is continuing to rise. And fortunately, the bulk of patients with bladder cancer are in manageable situations. And much like testicular cancer, we see a high number of people living with bladder cancer. So the incidence is 83,000. The prevalence is quite high at almost 750,000 people. Risk factors, these are things we're generally familiar with: smoking, workplace exposures, chemicals or dyes, arsenic in drinking water, elder age, male sex, and then there are some hereditary cancer predisposition syndromes. The bulk of patients who are diagnosed with bladder cancer have these confined to the bladder walls. Obviously, that's a good thing. The lower the stage, the higher the likelihood of being cured of one's bladder cancer, and the less likely it is that it would be responsible for their death. So now if we focus a bit more on the proportion of patients with localized bladder cancer, about 3/4 of these are going to have non-muscle invasive bladder cancer. Muscle invasive bladder cancer, of course, is associated with a 5% likelihood of being alive in 2 years if no standard of care was administered. And our standards are cystectomy with or without perioperative chemotherapy, or chemo radiation with or without systemic chemotherapy. So when we look at the numbers, about 60,000 patients in the United States are diagnosed with non-muscle invasive bladder cancer. And then of these, about 25,000 are high-grade non-muscle invasive bladder cancer. And when we start risk stratifying non-muscle invasive bladder cancer, it's really the grade that's going to drive clinical outcomes of recurrence and progression. So when we all sit down and talk to our patients with newly diagnosed bladder cancer, non-muscle invasive, these are the outcomes of interest. We're trying to keep these from coming back, and then we were trying to keep these from progressing into tumors that could require more intensive therapy or pose a threat to one's life. So of patients that have high risk non-muscle invasive bladder cancer, those that are high grade or CIS, ultimately over about half of those will recur within a year of currently available intravesical therapy. And about half those patients will become unresponsive to BCG, which has been and remains the standard of care for the last 50 years or so. And about 30% of the cases are actually going to progress to muscle invasive bladder cancer, requiring either cystectomy or chemoradiation, or go on to progress to metastatic disease within 5 years. And delaying progression here is critical because muscle invasive bladder cancer is associated with poor survival. And this really highlights the need for effective intravesical therapies in appropriately selected patients to help them keep them alive and recurrence free, and ideally with functional bladders intact. And something I'd ask everybody in the audience to consider: when you have patients that recur after initial BCG, what are you kind of thinking about in terms of long-term management of these patients? So that can be something that perhaps we could discuss towards the end of this webinar. So um, obviously, one of the options, which currently still remains the gold standard, is radical cystectomy as a guideline recommended surgical therapy for high-risk BCG unresponsive non-muscle bladder cancer, but it does come with side effects. So if you look at large surgical series, there's about a 40 to 60% 90-day complication rate after radical cystectomy that can result in both short-term and long-term morbidity. And these can include gastrointestinal issues, ileus, or bowel transit problems, infectious, urinary tract infections, superficial skin infections, intra-abdominal abscesses. And the mortality rate does approach somewhere between 2 to 5%, depending on the series that you look at. So it's a big operation. It can easily be 6 to 8 months before patients really kind of get back to their pre-surgical baseline. And, while it's absolutely, the appropriate next step in many patients, if that could be safely avoided, that could be associated with an improved quality of life. And when we talk about quality of life specifically, cystectomy can lead to changes in quality of life from adapting to urinary diversion. And of course, we bring up the options of neobladders, conduits, maybe pouches in appropriately selected patients. Even with all of that, there can be impact on quality of life, altered body image, and loss of sexual function. And of course, sometimes if patients are unfit or unwilling to receive surgery, cystectomy may be relatively or absolutely contraindicated, depending on comorbidities, frailty, and surgical risk. And I think these are kind of tough conversations. Certainly, if somebody's referred to and they've never heard that cystectomy may be a part of the treatment requirements for the non-muscle invasive bladder cancer. Um, and these are tough questions where we're trying to sort out, can we safely try to save your bladder, or are we potentially missing an opportunity of window for cure if we were to attempt a bladder sparing approach? Just make sure I didn't slip us. Okay, so now I'd like to introduce Adstiladrin, and the medication is a non-replicating adenoviral vector-based gene therapy indicated for the treatment of patients with high-risk BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ, with or without papillary tumors. And without going through the entire history of it, the FDA does require carcinoma in situ to be present to more completely assess the impact of the actual therapies. It's contraindications with patients with a prior hypersensitivity reaction to interferon alpha or to any component of the product. And we'll run through some of the safety information once again. So, in terms of guidelines, it is within the NCCN clinical practice guidelines in oncology for bladder cancer, and specifically, it receives a 2A recommendation, whereby nadofaragene faradonovec may be considered for the treatment of patients with BCG unresponsive high-risk non-muscle invasive bladder cancer with CIS, with or without papillary TA or T1 tumors. And the combined American Urology Association Society of Urologic Oncology guidelines discuss this for patients with BCG relapses, including salvage regimens. And the statement here is, in a patient with persistent or recurrent high-grade non-muscle invasive bladder cancer within 12 months of completion of adequate BCG therapy, who is unwilling or unfit for cystectomy following 2 courses of BCG, a clinician may recommend clinical trial enrollment as an alternative intravesical therapy, such as nadofaragene faradonovec, or alternative intravesical therapies, including gemcitabine and docetaxel. And this is given a grade C recommendations. And these guidelines are available for public consumption on the AUA and the NCCN guidelines. So the bladder, as we all know, is an ideal organ for local gene therapy. First off, given the fact that it's intravesically administered, the urothelium is generally not very absorptive. We typically don't see substantial systemic side effects. We also get direct contact between the gene vector and the tumor cells. The local administration limits systemic exposure, and it's pretty easy to monitor the effects of therapy with cystoscopy. And the gene therapies help fight cancer by essentially bolstering an immune response and protecting other organs from the side effects of the treatment. So in that regard, it really is kind of an ideal therapy. And Adstiladrin is a unique monotherapy to treat non-muscle invasive bladder cancer. And the gene therapy harnesses the body's own immune system to fight tumors. And more specifically, it delivers human interferon alpha 2b gene cells to the bladder urothelium, which penetrates the urothelial cells and travels to the cell nucleus, delivering the interferon alpha 2b gene. And while both normal urothelial and tumor cells in the bladder take up Adstiladrin, they begin high expression and transient local expression of interferon alpha 2b, which is a cytokine that the body uses to fight infections and cancers as well. Interferon alpha 2b has anti-tumor activity, enhances the body's ability to fight cancer, and can be given to patients when they first become BCG unresponsive. And currently, importantly, in the context of our international and national BCG shorters, no BCG co-administration is required. So we will walk through some of the clinical data that led to the approval of Adstiladrin. And the landmark study was a multi-center phase 3 open label single arm clinical study published in the Lancet Oncology. The key eligibility criteria were age greater than 18 years. They had to have BCG unresponsive non-muscle bladder cancer with a performance status of less than or equal to 2. And there were 2 cohorts, a CIS only cohort and then a high grade TAT1 cohort. About 2/3 of the patients were in the CIS cohort, and these were people with CIS with or without papillary tumors. And then the 50 patients in the TAT1 cohort had high grade TA or T1 without concomitant carcinoma in situ. They received Adstiladrin. This was 75 milliliters intravesically every 3 months with a 1-hour dwell time. And the trial did not include retreatment or reinduction for patients who do not achieve a complete response. And this is the primary endpoint was a complete response in patients with carcinoma in situ with or without papillary tumors at any time after the first installation. Key secondary endpoints, which are pretty typical in non-muscle invasive bladder cancer trials, were the durability of a complete response in patients with CIS or TA or T1 disease who achieved a complete response, high-grade recurrence-free survival in patients with high-grade disease, the durability of the response in patients with papillary high-grade disease, the incidence of and time to cystectomy, and then overall survival and safety profile. Pretty rigorous methodology with mandatory biopsies taken at 12 months, after which patients entered a 4-year follow-up, and those who remained high-grade recurrence-free could be offered continued treatment at investigator discretion. The safety and efficacy populations were of the safety population was 157 patients who were enrolled and received at least 1 dose of Adstiladrin. Again, this is 107 that had CIS with or without papillary tumors and 50 with papillary tumors only. 6 patients did not meet the definition of high-grade BCG unresponsive disease and were subsequently excluded from the efficacy analysis. And the efficacy population was 151 patients, 103 with carcinoma in situ with or without papillary disease, and then 48 with papillary disease only. And then in the final analysis, 98 of the 103 patients were considered evaluable for a response. So we'll start out with the baseline characteristics. And this is kind of what you'd expect for a bladder cancer population. The median age was 70, ranging from 44 to 89. And about a third of the patients were over 75 years old. 88% of the patients were men. 92% of the patients were white. And the tumor pattern at entry was carcinoma in situ with T1 disease in 5% of patients, CIS with TA disease in 19% of patients, and then CIS only in 74% of patients. And the median number of installations of prior BCG was 12, ranging from 8 all the way up to 18 for those that receive a bit of a longer maintenance course. So the primary endpoint, as I mentioned earlier, was a complete response rate, and 51% of the patients who were evaluable ultimately did have a complete response. And all complete responses were noted by month 3 after only one installation. It's kind of nice because you get a readout somewhat early on whether or not this medication is likely going to work. Duration of response of the patients that responded was 9.7 months, ranging from 3 to over 1 year, with over half of these having a response greater than 1 year. And when looking at the complete responses durability, at 1 year, 46% of the patients remained free of a high-grade recurrence, and at 5 years, 11% of the patients remained free of a high-grade recurrence. At 57 months, a quarter of the patients had an ongoing response at the time of last assessment, and any patient lost to follow-up or who switched therapy was considered a treatment failure. So again, rigorous methodology in terms of identifying and defining complete responses. And this is the longest term follow-up efficacy and safety data reported for a novel agent for BCG-unresponsive non-muscle invasive disease. A key patient-centered goal is bladder preservation, and the cystectomy-free survival rates at 1 year were about 3/4 of the patients were cystectomy-free, and at 5 years, about half of the patients were cystectomy-free. And among all the patients in the CIS cohort at 5 years, 96% did not progress to muscle invasive disease as assessed by TURBT at recurrence. So that's kind of nice to be able to tell patients that despite the fact that we may be delaying your cystectomy, which could ultimately be required, we're not seeing stage progressions that put you at an increased risk of recurrence-free and cancer-specific mortalities. So it's intravesical, it's localized, and the safety profile is fairly favorable out to 5 years. 3/4 of the adverse events were mild, grade 1 and grade 2, with only 11% of patients having serious adverse reactions. The bulk of these were less than 2 days and transient and local in nature. 2% of patients discontinued treatment due to adverse reactions, and dosage interruptions due to adverse reaction occurred in about 34% of patients, and 0 deaths were attributed to estrogen-related adverse reactions. At 5 years, there's no new safety signals, no deaths due to treatment, no grade 4 or 5 adverse reactions, and no new study-related adverse reactions as well. Here we'll look at them in a bit more detail. So installation site discharge in about 33% of patients. Some fatigue. Again, this is initiating a systemic immune-based response. So that's in 24 patients. Chills and fevers in 16 and 15% patients respectively. Urinary symptoms including spasms, urgency, hematuria, and dysuria, you can see occurred in about 20 to 16% of patients. I also want to highlight once again that there were no grade 4 or 5 drug-related adverse reactions. So the clinically relevant adverse reactions in less than 10% of patients who received Adcetris included coronary artery disease and acute coronary syndrome, AFib, dehydration, hypoglycemia, low blood sugar, syncope, heart failure, pericarditis, brain edema, bile duct stone, and sepsis. So uncommon to see serious adverse reactions. There were some laboratory abnormalities that worsened from baseline in patients with non-muscle invasive disease. In the CS003 study, you could see that glucose increased at a grade 3 or 4 level in 6% of patients, triglycerides in almost 2% of patients, phosphate in 1.4% of patients. All grades, these were at slightly higher rates, but in terms of 3 or 4, it was pretty mild. And then we saw some modest decreases in hemoglobin over the study population. So again, national and international guidelines such as the NCCN and the AUA SUO guidelines recommend Adstiladrin as an option for patients with BCG unresponsive high risk non-muscle invasive bladder cancer with CIS, and as a alternative to cystectomy in patients with these same disease characteristics. So a bit about dosing and administration. It was designed by a urologist for urologists, and it streamlines the treatment with convenience for both urologists and patients. It's quarterly dosing. I think generally patients are big fans of that. There can also be some equity and access issues for people that are traveling that makes this much more easy to manage. It allows us to continue to take care of these patients and coordinate their cystoscopies and so forth. The administration is pretty straightforward. There's no reconstitutions or dilutions. And again, in the current BCG shortage, BCG co-administration is not required. So it's supplied in a ready-to-use formulation, and it's provided in a carton containing 4 vials. Each of these has an extractable volume of 20 milliliters, and ultimately each dose of 75 milliliters is administered through a catheter, and it's indwelling for 1 hour. Pre-medication with an anticholinergic is recommended before each installation. It is, again, for intravesical therapy only, and it's not to be given IV, topical, or orally. So the way it works in terms of shipment and storage is shipped frozen at minus 60 degrees and can maintain the required temperature for at least a minimum of 72 hours if sealed. And then you got a couple of options depending on the freezers that are available in your clinic or center. If you have a minus 60, it can be stored until the expiration date printed on the carton. If it's between a minus 25 to minus 15 degree, you get up to about 3 months without exceeding the original expiration date. And then once you receive it and it's getting closer to the administration, you thaw it at room temperature or in a refrigerator. And there's a little bit of variability in how long the thawing process could take. There is a cardboard nest that's provided. If it's within the nest, it's usually on the order of about 10 hours, give or take. If it's outside of the nest, it's more like 3 or 4 hours. And then after thawing, you keep it at room temperature or refrigerated. And this can be between 2 and 8 degree fridges, up to 24 hours at room temperature or 7 days refrigerated. Importantly, once it's been thawed, you don't want to freeze it again. And then finally, for administration, you bring it to room temperature. And then after withdrawing the suspension at syringes, it may be stored for up to 6 hours at room temperature. And we can talk towards the end about some of the logistics to make sure that the patients are ready. They're going to show up before we thaw and prepare these. A bit on ordering and reimbursement. So in our experience, the Ferring hub support team is quite effective. And once the patient's been identified, an eligible patient submits a patient enrollment form. We, of course, submit that on their behalf. And a completed patient enrollment form is faxed or sent online to Ferring. And then their access support team will conduct a benefits investigation, including information around a patient's coverage. This is always a question that pops up for both patients and hospitals. And then you set up an account and order the Adstiladrin. And that's pretty straightforward with either Bessie Medical or Optum Frontier therapies. And once the benefits coverage is confirmed, you can go on to the order, and then essentially the installations are scheduled and carried through. Here's some contact for the Ferring access support team, and this is a good number to keep. So Ferring, again, they have a really wonderful support system. There's the copay program where eligible commercially insured patients may pay as little as $100 for each prescription. There is a replacement policy where Ferring will replace select Ferring products purchased directly from Ferring or Ferring authorized distributors without charge. And then there's Ferring Assurance, where if an office receives a positive coverage determination through a Ferring reimbursement support center, and if the reimbursement is subsequently denied due to inaccuracy by or from Ferring, they'll reimburse the acquisition cost of the product. So this kind of helps take off some of the some of the financial burdens that practices may be nervous about. Pretty well covered. Adstiladrin has confirmed 99% coverage for commercial and government insured patients with almost 300 million lives covered and a pretty straightforward ordering experience with established NCCN guidelines, J code, pass-through status, ASP. And it's on the VA formularies as well. So Medicare Part B confirmed Adstiladrin reimbursement and paid claims at Medicare administrative contractors. And here you can see sites of those distributed throughout the country. CMS guidance has confirmed that Adstiladrin Medicare Part B reimbursement of ASP at 6% and confirmed paid claims and accurate fee schedule at all MACs since the establishment of ASPs and about 22 days average reimbursement from the MACs. And here are a couple of QR codes to learn more about reimbursement and pricing. So kind of at a high level, as we conclude the presentation part of this webinar, proven complete and durable complete responses. 51% of the CIS cohort achieved complete response by month 3 after 1 installation. Of these, almost half of the patients remained free of high-grade recurrence at 1 year, and then about half of the patients in the CIS cohort were cystectomy-free out at 5 years. Well tolerated with 75% of adverse reactions that are grade 1 or 2 and resolved quickly within 1 or 2 days. Serious events occurred in about 11% of patients, 0 grade 4 or 5 drug-related adverse events, and then only 2% of the patients discontinued due to adverse reactions. And over the 5-year program, no new adverse reactions or safety signals came out. The dosing schedule is convenient, once every 3 months, no BCG required. This was created and designed by urologists for urologists with pretty seamless integration to our workflows that we're all quite familiar with. And then finally, confirmed coverage and reimbursement and a guideline directed option per the NCCN and AUA algorithms. So I thank you for your attention. I'll stop sharing my screen at this point and happy to take any questions. Okay, so there's the first question that comes through is, knowing that Adstiladrin is dosed every 3 months, when do you bring patients in for a cystoscopy in advance of their next treatment? Yeah, great question. So generally, let's say a patient's completed BCG and office cystoscopy confirms something suspicious, and they go on to receive a TURBT confirming CIS with without papillary disease. Now we're starting to have a conversation about next steps, and if Adstiladrin is thought to be the next appropriate step, we go to the access support, submit the patient enrollment, and that process is usually pretty straightforward. It takes about a week or 10 days, up to a couple of weeks. Once the installation is done, what I'll typically do is schedule the cystoscopy in 3 months. When we do the patient enrollment, we try to get all the coverage for 4 installations, assuming they're going to have a good response. So do the cysto, and then a week later, set up the next installation. And one, just want to make sure that it was working, and at the cysto that there's no evidence of disease recurrence. And then secondly, before we kind of commit to the second installation, we want to make sure that we have a contemporary urinalysis symptom check-in to make sure they don't have any contraindication to receiving Adstiladrin. Great question. Thank you. Another question that came in, do you use anticholinergic with all patients before Adstiladrin installation? And when you use it, which anticholinergic do you use? So the short answer is we try to use an antispasmodic. I'll generally try to get a beta-3 agonist just because of the fact that it's a little bit less in terms of cognitive impact on older patients. It's not something that's on the label, but kind of within the community of providers that administer Adstiladrin, sometimes Valium can also be uh, efficacious and more specifically rectal volume. If the patient were to have a spasm and urinate the drug, the nice thing is it can be covered and a replacement dose provided by fairing, but it does introduce logistics. There's consternation at the level of the patient. So we have gone to patient to using a anticholinergic prior to all installations. And generally, since these patients have received intravesical therapies before, we have a good sense of how that goes. And I always specifically ask them, how did you do with your BCG or with your other intravesical installations? If it was like a walk in the park, we can have a conversation about the pros and cons. But if they had issues with frequency, urgency, dysuria, then absolutely would recommend using an anticholinergic. Last, how's the patient experience with that Silden been in our practice so far? Honestly, it's been really, really positive. I think there's a couple of things that are noteworthy. One, even over the course of the time that the patient started out their bladder cancer journey, uh, the fact that there's new options, safe, highly efficacious bladder sparing options, I think is really, really a source of hope for the patients. Secondly, and initially I didn't appreciate kind of what a big deal it was for patients from both the convenience, cancer care delivery standpoint, but the quarterly dosing is actually really nice. Where we are in San Diego, we have a lot of people coming in from the kind of inland empire, and for them to kind of come in once, get their treatment, and then get on with it, as opposed to every week for 6 weeks, I think is really, really positive. And we haven't really seen any major issues with adverse events to date, and that's after having about a 1 year experience. So very positive. Well, I'd like to thank you all for spending a little bit of your Thursday afternoon learning about this medication. By all means, there's some contact information from Fairing within the slides. Feel free to reach out to your local representatives. Please feel free to reach out to me directly. And thanks again for your time and attention. Appreciate it.